Okay. So first we have Bree, who will be presenting 4 flash talks on some of the great work being done at the Autism Clinic. So you can go ahead.
Okay, I am going to work on sharing my screen. Just 1 second. Sorry. There we go. Had to make sure it was going to register my second desktop. Okay. Let's see here. So I am, can you guys see this okay?
Yeah.
Okay. So I'm going to present on several different projects that members of our lab, the Impact Lab, presented at the 3rd annual Interprofessional Health Symposium at Dell Medical School this past April. So each of these 4 projects are centered around improving access to care and equitable service navigation for autistic individuals and their families. The first project is aimed at improving access to diagnostic evaluations. So this project is sort of the cornerstone of the whole research program in the Impact Lab, and it also sets the stage for the second and third projects that I'll discuss. The second project focuses on measuring patient and family experience in the Diagnostic Clinic and is part of our ongoing program evaluation efforts. The third project emerged from a research assistant who has a particular commitment to supporting autistic women and girls. And finally, I'll describe some of the emerging efforts in a medical legal partnership to connect families with educational advocacy services and pro bono legal representation through a partnership with UT Law. In terms of timing, I'm going to spend about half of my time on just the first project, and then I'll split the rest of the time between the last 3. So the Diagnostic Clinic project was initiated and led by Drs. Ravenscroft and Brinster, so from developmental behavioral pediatrics and pediatric psychology. And at this point, it's expanded to include a large interdisciplinary team of faculty, staff, and students with the shared goal of improving the autism diagnostic process. That process is sometimes referred to as an Odyssey. And we focus on early diagnosis because our lab is affiliated with a pediatric specialty clinic. And that mostly serves school-age children or infants and toddlers. So typically in the US, when families are seeking an autism evaluation, that process moves pretty slowly and it requires moving through multiple steps from initial concerns all the way to eventual diagnosis. That entire process can easily exceed 1 year. And like I said, it's been described as an odyssey, largely due to the financial strain, the potential emotional distress, and the series of systemic barriers that characterize the entire process and further contribute to healthcare inequities. So this is a really serious issue, partially because most families can't afford to pay out of pocket for the time-intensive behavioral, speech, or occupational services that are associated with adaptive and educational gains for this population. And because of that, this long journey towards diagnosis ends up becoming a bottleneck, and it delays families who are seeking access to the services. So it's not about just getting a label, it's about the functional impact of getting that diagnosis in order to make a pathway for services. So to address these challenges, just a really broad overview, the team developed a 5-step model, including family navigation, incoming and outgoing referral pathways, comprehensive interdisciplinary evaluations utilizing gold standard measurement tools, and the provision of a single set of brief and individualized recommendations and referrals that the family receives support in following up on. So this model relies pretty heavily on pre-visit preparation, a series of sort of team conferencing that takes place, post-diagnostic follow-up, and the presence of learners and trainees in a teaching hospital. As you can see, the patient population seen through this clinic is quite diverse. Roughly half of the families identify as Hispanic or Latino, And again, roughly half are insured through Medicaid or CHIP plans. We also have a large Spanish-speaking population, many of whom are bilingual, but roughly 15% speak Spanish exclusively. And to evaluate this program, we obtained a waiver from the IRB, as well as approval from Seton Ascension to access health records retrospectively. We had a bunch of research assistants who were trained to 90% inter-rater agreement on practice records before entering chart data for the project. We first analyzed efficiency. So we wanted to look at the total time to diagnosis from the time that our clinic, the specialty clinic, receives a referral from primary care, all the way to the time when a family actually receives their diagnosis, if appropriate. So that's what we're calling time to diagnosis. And we also looked at the wait list. So the kind of period of time that families are waiting before they even get their foot in the door. Then we investigated equity by exploring whether time to diagnosis varied according to any socio-demographic factors that we had access to. And finally, we measured the impact of this program by identifying the number of patients who were newly referred to evidence-based interventions through our clinic. In the first year, which spanned from, I think, June of 2018 to 12 months later, the program served 173 patients under age 4 who were referred for an autism evaluation. In terms of efficiency, the waitlist was reduced by 77%, and that's including continuous new referrals. And the average time to diagnosis was under 3 months from the date of referral to the date of receiving a diagnosis. So meaning that most of these families, the vast majority, are receiving that diagnosis in the single new patient appointment, which is 90 minutes long on the books, kind of goes over sometimes. But about 90 minutes, they're able to actually get what they need to see if they qualify for a diagnosis of autism. Sometimes families do need to come back for a follow-up appointment, but this time to diagnosis average metric takes that into account. So on average, under 3 months. There were no significant differences in these outcomes across race, ethnicity, language, or insurance type. And in terms of impact, as you can see in this figure here, many of the families were newly referred to evidence-based interventions through this program. The most notable impact is for applied behavioral analysis, which you can see the light blue bars show the number of patients who were able to receive that diagnosis before they were referred to STAR. So only 12 patients out of our 173 here were receiving ABA services, even though they were identified as at risk for autism. And after coming through the clinic, an additional 104 patients were newly referred to this service. So the initial results are really encouraging, and our team is really proud to play a role in improving access to services, mostly within the Central Texas region. Programmatically, there are a number, kind of always coming up with new spin-off future plans that are unfolding within the clinic or have plans to materialize as soon as possible, including a team of providers who will conduct the interdisciplinary evaluation in Spanish. And the team is also looking to expand the age range upwards into early elementary by adding a second clinic day and incorporating medical residents and other learners. In terms of the research and evaluation efforts, though, I'll focus next on how we attempt to measure the patient and family experience in this clinic. So this particular project was presented by Crystal Lee, a junior at UT in the pre-med track. And we were all really proud of Crystal for presenting this to a panel of judges at IPHS. She was a finalist in the quality improvement category. So as I've already described, our team developed this new model, but I haven't up to this point mentioned anything about the family's experience going through this clinic. I did describe that the journey towards getting an autism diagnosis can be arduous, it can be stressful, inaccessible, fragmented. Therefore, it is really critical that we collect feedback from families who are seen in this clinic. To attempt to do that, our team reviewed the patient satisfaction literature in pediatric subspecialty care, as well as several satisfaction measures that were more specific to autism service navigation. We identified 2 existing surveys with good psychometric properties and obtained permission from the publishers to use them in our clinic. The full survey that we ended up with included 14 items, which were a combination of Likert scale and open-ended, which asked the patient's caregiver to report on the quality of staff and provider interactions, the speed and quality of diagnostic services, the helpfulness of information provided, and perceived cohesion across disciplines. This took us a little while to actually launch because we needed to provide it in both English and Spanish, and also figure out the logistics involved in sending a clinic-specific survey within the hospital, which took a minute. But we officially began collecting surveys from all STAR patients in November of 2020, which was while we were providing almost exclusively telehealth services. At the time that Crystal pulled data for this project, we had sent the survey to 67 families. And as of today, just checking our database, the numbers increased to 107. So the responses that we do have are very positive. 100% of respondents felt that the providers had strong interpersonal skills, listened to them carefully, explained their child's development in a way that was easy to understand, and provided very helpful information. 85 to 95% of respondents felt that they were very satisfied with the speed of the diagnostic process, the communication between different professionals, and that there was a clear structure to the process for which they were prepared in advance. And that's kind of our metric of coherence. So it's encouraging to get this type of feedback, but what we're focused on at the moment is not the results themselves, but the response rate and the representativeness of these responses. So families may have different experiences within our clinic based on their cultural values and norms, their lived experiences, and the history that they've had with different aspects of the service system. So as you can see from the figures here, the two on the left demonstrate the racial and ethnic demographics of all of the patients that were sent these surveys. And then the figures on the right show the same breakdown, but for families who completed the survey. And so we're seeing two things. One, we don't have a very good response rate overall. We had sent it to 62 patients and had received it back from 11. So it was around a 17% response rate. And then also the kind of composition of the different families who were sending that survey back to us wasn't representative of all of the families that we see in STAR. A few things have changed in the past month and a half. One is that most of the appointments are now taking place in person as opposed to almost exclusively via telehealth. And also Caroline, the social worker in the clinic, is following up with families who have not completed the survey. By the time that she meets with them for their virtual follow-up appointment, she'll talk with them about the experience that they had and kind of solicit some of these responses at that point. So since adding this additional opportunity and transitioning to more in person, our response rate has increased by several percentage points overall, and the percentage of responses from Hispanic and Latino families has risen to 33%, which is closer to the overall clinic demographics. So this is a work in progress. We're using the kind of Plan, Do, Study, Act quality improvement framework to keep moving this onwards next year. This next project was developed by an undergraduate research assistant, Kenza Magani. She just completed her senior year at UT and will be attending medical school in the UT system beginning this fall. We were also really proud that Kenza submitted this and presented it as a finalist in the research category at IPHS. So Kenza became very interested in how autism presents in women and girls, and specifically the theory that current diagnostic criteria might be male-centric. So the way that our understanding of autism and the diagnostic criteria looks right now may be kind of built around our understanding of what it looks like in mostly boys. And so therefore, maybe we're not capturing neurodivergent females quite so well. With that kind of overarching concern in mind, we started by considering social camouflaging and how this phenomenon might impact diagnostic assessments. So to start with a quick definition, social camouflaging is also sometimes described as masking, and it's when an autistic person works to suppress behaviors that might be less socially acceptable or normative, and they mimic or adopt what they observe in neurotypical peers. So it's a kind of attempt at blending in, and it can reportedly take a great deal of energy, leading to feelings of exhaustion or burnout. There's also been some suggestion that autistic women may camouflage more than autistic men, which leads to the concern that diagnosticians might miss women and girls who are camouflaging their autistic behaviors. As it turns out, this was actually a really difficult place to start in developing a research question and strategy, largely because we don't have an agreed upon measurement of social camouflaging yet, especially in young children. There's a self-report tool called the CAT-Q, but there are concerns that it's more of a social anxiety measure. Also, it's a self-report tool, so wouldn't really be applicable in infants and toddlers. Then there's another way of measuring it, which also has some criticism, but ultimately we didn't have access to either of those options anyways. So we couldn't quite look at social camouflaging per se in our sample of kids, but knowing that we couldn't do that, we instead chose to measure social communication symptoms rated through a combination of behavioral and behavioral observations and parent report to see whether young girls with autism were rated less severely in this area than young boys with autism. So based on the available data, we came up with two questions. Do we observe sex-based social communication differences in young children with autism? And if so, do those differences persist after controlling for cognitive delays? To explore these two questions, we did a retrospective chart review of 155 patients aged 2 to 5 who'd been diagnosed with autism in our STAR Diagnostic Clinic. As part of their evaluation, the provider team completes the Childhood Autism Rating Scale, second edition, and that's kind of a summary measure. So the clinician is able to pull together their behavioral observations, what they've heard from the parent in developmental interviews, and also any results that they've obtained from formal developmental testing, all of the different sources. And they kind of organize these by different symptom clusters and get a total score. So that's what we used. And to account for some of the heterogeneity in autism, we chose to do a matched pairs analysis and directly compare male and female patients of the same chronological age and autism severity score. So that led us to end up with 38 matched pairs, which we ran independent t-tests on. So when we looked at their total score, so all of the symptoms included on the CARS-2, even including things that are not necessarily specific to autism, like hyperactivity, we saw that males were rated slightly more symptomatic in this clinic overall than females. And that was by about 2 points on a T-score scale. And again, this is across pairs that were matched by age and symptom severity. But we didn't see this slight difference expressed in any of the social communication items specifically. So that includes imitation, relating to people, emotional response, and nonverbal communication. Then we added an additional variable into the matching criteria. We kept age and severity level, but we also included kind of a rough metric for cognitive ability, which was the presence or absence of a co-occurring global developmental delay, which the team uses a pretty consistent battery to determine. So they pull from they use the developmental profile third edition and the Mullen scales of early learning alongside the whole rest of the evaluation to determine whether a global developmental delay is also present. This left us with 35 matched pairs, and the overall differences that we had seen previously in symptom severity disappeared. And we also continued to observe no differences in any of the social communication items. So these findings led us to several conclusions, very preliminary conclusions, and these are informing our next steps on this project. So first, if there are sex differences in autism symptom presentation during early childhood, they don't appear to be linked to the social communication domain, at least as currently conceptualized and measured through the CARS-2. It's possible that this might emerge later in development. These were 2 to 5-year-olds, and So, as social demands increase and social behaviors become more sophisticated, maybe it would emerge a little bit later. And this also does sort of align with findings from other groups, which should suggest that co-occurring disruptive behaviors in young boys are actually more predictive of their early autism diagnosis, and that restricted and repetitive behaviors might look different in young boys and girls in terms of type, intensity, and changes over time. So kind of, again, adding to maybe instead of just looking at social communication, we should broaden the lens and look at other aspects of behavior and symptom presentation. So our two-step matching criteria also highlighted the importance of controlling for cognitive ability in these types of studies. Ideally, though, using scores from a single cognitive or developmental measure, instead of having to just pull in the absence or presence of a co-occurring delay. And of course, there are several limitations to the study, including that we used a retrospective chart review and a convenient sample obtained from a single clinic. We're also concerned that the matched pairs approach, although useful in providing sort of a true one-to-one comparison, also meant that we lost a lot of our data because we had so many more males than females. And then by matching them, we can only use a subset of the males. So moving forward, we're planning to broaden our research question. We're looking at there's a factor structure that's been researched for the CARS-2, and so we're going to apply that and look at across the different factors, and also using a regression approach. Okay, so I will briefly talk through a community engagement project geared towards connecting families to educational advocacy. And this project is led by Caroline Turner and Lucy Wood, and it was presented at IPHS by Gabby Taylor, who is about to graduate with her master's degree in social work from UT. Many of the patients seen in the developmental pediatrics clinic at Dell Children's have diagnoses like learning disabilities or autism that warrant additional support in schools. And in some cases, accommodations through 504 are appropriate. And in other cases, specially designed instruction or intervention through special ed is appropriate. But occasionally, families talk with their healthcare providers in our clinic about the difficulty that they face in obtaining appropriate educational services in their child's school. So two common concerns that can come up are difficulty getting a child to qualify for special ed specifically under the category of autism, even if they have a medical diagnosis of autism, and then also feeling that their child's 504 or IEP is not being followed as outlined. So healthcare providers have a difficult time providing individual advocacy in these situations because of time constraints in clinical practice, a lack of expertise in special education law and district procedures, and also the privacy laws within education and healthcare that require additional paperwork and for any kind of interagency communication. Luckily, there's a program based out of UT Law, which can provide pro bono educational advocacy services. So through a medical legal partnership that was developed between the developmental clinic and the Include project, a referral system was put into place. And over the past year, 27 families representing districts across 6 different Texas Education Agency regions in sort of Central and East Texas were connected with pro bono advocacy training and or legal representation. Children whose families were referred ranged in age from 3 to 13, although mostly these were kind of clustered around the elementary and early elementary age range. The majority of these kids had more than one medical diagnosis. So for example, autism and epilepsy, and therefore had kind of more nuanced or complex support needs. Moving forward, the plan is to continue sending referrals to the Include project, which has been a really, really helpful resource for families, and further developing this partnership and specifically combining forces with the educational advocacy program at Dell Children's hospital-based campus, which already provides support to families of children with chronic illnesses or acquired conditions, or children who are in recovery from medical procedures and therefore in need of formal accommodations or IEPs. So I hope the captions helped the fact that I was speaking as fast as I possibly could, basically. But that is an overview of these few projects. I will stop sharing and if anyone has time for a few questions, Caroline's here too. And I don't know if anyone else from DBP, Meg, Mia, Tony, so we'd be happy to try our best to answer any questions.
Sandra, how much time do we have for questions?
We originally planned to have about 5 minutes per presentation afterwards for questions. So,
Okay.
So we can definitely move on with questions from anybody, and you can feel free to unmute and ask away.
I just have a comment. I think this is amazing. You guys have an incredible amount of data, really rich data from the clinic. And each of these projects was really, really fantastic. I was gonna just make a comment about the girls versus boys analysis. That is really interesting. I'm wondering if, you know, because this is a convenient sample of who's coming to the clinic. And so I'm wondering if boys are more likely with intellectual disability are more likely to be referred to the clinic versus boys who are not, or, and then why are girls who don't have intellectual disability more likely to be, I don't know, something going on there too, in terms of who's actually being seen by the clinic and why. Something to think about.
Yeah, I think we're really interested too in thinking about even just like the name of our clinic, developmental and behavioral, thinking about maybe more of these referrals are coming at us because of the sort of disruptive behavior and hyperactivity. So maybe, you know, some of that is displayed a little bit more in the boys, or maybe that's driving some of this difference that could be at play as well. So it's hard to say, yeah, because we sort of just have this clinic sample. But I don't know, and the intellectual and cognitive ability piece would be interesting if we were able to maybe down the line continue to have some follow-up experiences with these families and could access some of their assessments in the future. That would be really useful, because right now we just have really early developmental indicators, and it'd be hard to say whether some of these kids actually end up with an intellectual disability diagnosis or not. So yeah, that would be interesting to look at. Oh yeah, Haley.
I have one question. It's a comment along the same lines, but slightly different. What I was wondering with the girls, that one particularly jumped out at us. Excellent job. Yeah, I mean, that was really, really beautiful research there. For the girls, one of the questions I'm sure you've already thought of, and that I think it has to do with getting assessments later, are the ones that come in, don't get a diagnosis, and then come later and get a diagnosis. Like, that seems really interesting to me, would be like, okay, what about, you know, what are those differences? I just don't know if you have that data, but that would be something that could be interesting.
Yeah, and I think so hearing some of what you're saying too, what's challenging to kind of parse apart here is, so some kids, they come in and it's really unclear at this age, and so there's some kind of like follow-up monitoring, and so maybe they don't reach diagnostic criteria at this age group, but maybe like a year or two down the line they actually do meet criteria, and then thinking about like, well, did we technically miss that, or were we just being careful about getting them speech services and things before thinking about really assigning the autism diagnosis. So that's so hard to pull apart from, you know, the missing of it versus like mischaracterizing it versus just not having enough to go on yet. So I don't know, it's, yeah. It's a good point.
Thank you.
Was there anything, DBP folks, did anyone else want to, Caroline, mention anything else that I missed?
No, you nailed it.
Thanks.
I don't think I see any more questions. Just congratulations. It's a lot of great work that you guys are doing. So really excited to see how where it goes. So I guess we can move on to our next presentation since we have a full program. And next we have Susie, Alberon, and Jenna Crank, who will be presenting on Project AIM.
Awesome. I'm just gonna push the share screen button and hope it works. Okay, yes, share. Did that work, guys? Yes, okay, great. Okay, so I'm gonna set my timer because I have a tendency to go over time, and then I'm gonna get started. So I'm just I'm gonna begin with a brief overview of what Project AIM is, and then I'm gonna get into what I'll start, and then Susie will come in after me. I'll talk about kind of the research that I've done individually. So Project AIM is this kind of a label for this, it's a research team and also kind of like a research project. It stands for Autism Intervention Meta-Analysis. And kind of the genesis of it was there was a significant increase in group design research for early childhood autism interventions, like between like 2010 and 2017. And it went from like, I think somewhere around like 10 or 5 all the way up to like 42 in like these 2 published systematic reviews. So there was like this, but there wasn't any large scale comprehensive systematic review of like the state of research across the board. And so there was kind of this this chasm that needed to be filled. And my mentor, Dr. Sandbank, was the lead author on the first paper that I'm going to summarize now before I get into the paper that I put out and some of the other projects from the group. So it began with a systematic search. The inclusion criteria for the studies were that they included young children who had a diagnosis of autism or related disorder that used to be considered, that falls under the autism category. It needed to be an intervention that was non-pharmacological, and it needed to be a group design study that has some kind of comparison. It could have been a control group or another intervention, something like that. And these are the search terms that we used. And so what my mentor and we decided to do was conduct a comprehensive meta-analysis of, the intent was to conclude all group design research of early childhood autism interventions. All right, so the systematic research that I showed you in the last slide yielded, yielded something like over 12,000 reports. But after we screened them for the inclusion criteria, we ended up with 150 reports, which represents 130 individual investigations. And those represented over 6,000 participants. And we were able to extract over 1,500 effect sizes for analysis. And we coded each study for lots and lots of different characteristics at the study level, the intervention level, as well as the participant level and the outcome level. For the purposes of the initial Project AIM paper, which was like the larger meta-analysis, all the group design research, the most relevant things are the types of intervention and the outcome domains. Because what we did was use a robust variance estimation. Doesn't really matter what it is. It's a summary of like a summary effect estimate that allows for you to control for different things that can confound data when you're doing meta-analysis. And what we did was look at the summary effects of these different intervention types, and they're listed here on the screen, behavioral, developmental, et cetera, on different outcome domains, like adaptive outcomes, cognitive outcomes, et cetera. So the results of that initial paper are here. So this is what the robust variance estimation looks like for all studies and all included outcomes, right? So you'll see if you go on the right, if you've never seen a forest plot before, don't worry about it. I've indicated where you see positive and significant effects. So you'll see in the behavioral category, so these are all the outcomes that were from studies that were coded as behavioral interventions. You see positive and significant effects for basically all of the included outcome domains. And then if you move down to the developmental category, you'll see positive and significant summary effects for social communication outcomes. And then the DBI has positive and significant summary effects for cognitive, language, play, and social communication outcomes. All right, and that's all you see on here. Those are all the significant effects. But kind of the interesting pattern that you start to see is once you start to limit the outcomes to ones that come from studies that are a little bit higher quality, like more methodologically rigorous studies. So the first step that we did was just remove non-randomized outcomes that come from non-randomized studies, right? So quasi-experimental studies and stuff like that. So you just kind of were limiting it to a little bit higher, like a little bit more rigorous, higher quality sample. Well, now you see that actually the outcomes, there weren't even enough outcomes from RCTs in the behavioral category to power the analysis. So we didn't get enough outcomes to even run the analysis. So we don't have a lot of information for that, except for that we need a little bit more, that there's a need for more RCTs in the behavioral category. But aside from that, we don't really get any information. But moving down, you'll see that the social communication outcome is still positive and significant for developmental interventions. And you'll see that NDVI has maintained its positive and significant summary effects for language, play, and social communication outcomes. But the cognitive outcomes have kind of moved a little bit to that left. And I know although they are still positive, they're no longer a significant summary effect. And then, oh, where'd it go? Once you limit it to only outcomes from randomized controlled trials that are not at a high risk of detection bias. So that means that they are for sure, that the coders and the assessors are for sure masked to intervention status. You don't get any significant or positive summary effects. And also you get almost no, there's not enough outcomes to run the analysis for most of the outcomes for like the outcome domains and most of the intervention categories. And so we just get a big frowny face. So the big takeaway of the initial Project AIM paper was, it was not to be like, you know, poo-poo, like research bad. It was more like low quality studies and outcomes are inflating our estimates of intervention effects across the board, like for all intervention types, for all outcome types. And so there's just, the takeaway is that there's an urgent need for more methodologically rigorous studies in our field, top to bottom, left to right. So just to quickly speed into my stuff, so I don't go over time. My paper that I kind of spun off from Project AIM, because like I said, we collected a lot of data from this very large data set, right? We have characteristics from participants and outcomes and all the stuff that we can analyze in different ways. So what I decided to do for my project was to do a meta-analysis and a meta-regression of all of the group design studies of naturalistic developmental behavior interventions. And the idea behind that was, like, at the time, although the interventions included in that category weren't new, and those are things like Jasper, Early Start Denver model, reciprocal imitation training, those types of things. Those aren't new interventions, but the category in DBI and kind of like the consensus that all of these different interventions are related to each other, that was new, and there wasn't any kind of robust systematic review of that type of literature. So that's kind of where the genesis for this was. And so there was 27 different reports of NDVIs included in the Project AIM dataset that I used, and I extracted 454 effect sizes for my analysis. I repeated that robust variance estimation analysis to get the summary effect of NDVIs across domains, just because the paper wouldn't have been whole without it. But it's just a repeat of the data from the initial Project AIM manuscript that I talked, or the initial Project AIM paper that I already talked about. So it's not really the meat and potatoes of the paper. What was really interesting was the meta regression that I conducted, that was basically trying to test different moderators to see how they interact with how they moderate intervention effects. So I'll explain that a little bit more. So what I did was I took all of the studies of NDVIs and I tested whether these different putative moderators, the participant characteristics that I tested were language age, chronological age, and autism symptomatology. The intervention level characteristics that I tested were intervention intensity. So that's just like the cumulative hours of intervention received, and the interventionist types. So that's like who delivered the intervention. Was it a caregiver? Was it a clinician? Was it a combination, a teacher, etc.? And then there's the outcome level characteristics that I tested, which is parent and teacher related correlated measurement error, which I won't get into because there's just not time. And also outcome proximity and outcome boundedness. And what those refer to are the proximity of the skill that is measured in the outcome to the skill that is taught in the intervention. So basically, a highly proximal outcome for an intervention that teaches like pointing to request would be measuring frequency of pointing to request, right? The exact same thing. That's a highly proximal outcome. Whereas like a distal outcome, which would be the opposite, would be like if you're teaching pointing to request and then you measure like language, like that's distal. That's not exactly what was taught. It's related and it's meaningful, but it's not a proximal outcome. The other moderator that we tested was outcome boundedness, and this refers to the context of measurement. So a highly context-bound outcome would be an outcome that is measured in an identical or very similar context to the intervention that was delivered, right? So if it's a parent, you got a parent training intervention, you teach a parent to do to be responsive and to kind of facilitate joint attention, and then you measure the child's joint attention with the parent in the home in a similar context with similar materials, that would be a highly context-bound outcome. Whereas a generalized outcome would be maybe a standardized assessment conducted by a clinician somewhere else. You know what I mean? Like those are the characteristics that we cared about. And so lo and behold, when I ran the moderator analysis, outcome proximity and outcome boundedness were did significantly affect intervention effectiveness, right? So highly proximal outcomes were significantly larger than distal outcomes, and highly context-bound outcomes were significantly larger than generalized outcomes. Now, this isn't surprising, but it is important because when, like you saw in the initial paper, if you just look at outcomes, if you just take them at face value, if you just take like the summary effective interventions across the board without digging into these details, you might say like, we're killing it. Like all of these interventions have all of these positive and significant effects. But if you look into the nitty gritty, it turns out that they're being inflated by things like this, right? And so let me go to the results so I can wrap up so Susie has time. So although NDVIs do show significant and positive summary effects for play, social communication, language, and cognitive outcomes, which is good, and I don't mean to say that it's not encouraging, because of these moderator effects that we found, and also some of the research in the initial paper, we have to be a little bit tempered in our interpretation of the effectiveness of this intervention, because it's just difficult to know how meaningful these outcomes are when we're not measuring things in a generalized and in like distal way. Because although it is important that we have effects on proximal outcomes, like if we're teaching joint attention, it's important that the child demonstrates gains in joint attention, like that matters. But there's also like the reason that we teach joint attention, for example, is that we're trying to affect larger, like broader development over time. And if we're not measuring generalized like cognitive, language, etc., like social communication outcomes, we're just not getting that information, right? So it's not like proximal outcomes and context-bound outcomes are bad, but they're just not the whole picture. And that's kind of the idea that we're trying to work at with this Project AIM stuff. So I'm gonna go ahead, I went over like I always do, so I'm gonna go ahead and stop, and I'm gonna let Susie pick it up because she has a few slides after this. I'm gonna mute myself.
Thank you, Jenna. Okay. So my extension on Project AIM was to see if there was a potential variation by domain. And so other things that were reviewed were language and play, and I was particularly interested in whether or not adaptive domains or cognitive scores, so not so much cognitive scores themselves, but cognitive domains and types of targets, if intervention effects varied by the type of targets that we were investigating. So for me, I was interested again in cognitive adaptive domains. And the reasoning was many children with ASD have these deficits in both cognitive and adaptive functioning. And we often measure intervention effectiveness by using tools such as the Vineland and other adaptive tools. And we often see that these are potential predictors of ASD severity. So again, adaptive and the things that you're able to do for yourself, and cognitive functioning, which includes many things. And many studies target these domains, but few studies have meta-analyzed the intervention results for these domains. And so of importance was who provided the intervention. And so here we see for adaptive domain or adaptive outcomes, or the type of outcomes that were being measured, we saw a lot of caregiver, clinician, and combination. And for the results of the meta-regression, I had about 40 studies and 82 outcomes for the adaptive domain. And what ended up showing significance or significant moderators of intervention effectiveness were who intervened, so who provided the instruction. And so we saw significant and positive effects for clinician interventionists and caregiver in combination. So we saw that intervention seemed to work better when a clinician, caregiver, or a combination of the two provided the intervention. And those were and I looked at various things such as the age of the child, autism severity, and language age. And here we see again for adaptive outcomes. Overall, we did see a positive effect for both adaptive and cognitive outcomes, telling us that in general, intervention is showing positive, improvement across the studies that were analyzed. And for here, adaptive domains. And then for cognitive, again, who provided the intervention? We saw a lot of caregiver, clinician, and combination. And we did see a lot of educator. And significant moderators of intervention effects were, again, caregiver, clinician, and combination. And in addition, for the, for the cognitive domains, in addition, we did see that language age did turn out to be a significant moderator. I believe one of these had technology based, as it must have been the adaptive domain. Technology based did turn up as the interventionist type being a significant moderator, but we only had like 1 or 2 studies of technology, so there just weren't enough studies to include that in as a result. Yes, so it was here for the cognitive domain. So the technology based interventions, we had just too few outcomes. And that's really it for mine. And some of the limitations were some of the same things, like outcome boundedness for sure did present a limitation for analysis. So yeah, that is all I have for you. Any questions for us?
Yeah, I tend to talk very fast and with very so please ask clarifying questions. I'd love to talk some more about it.
I have some questions this is great. I really love this project. I mean, you guys have been producing some amazing findings, and this is a fast growing area of study. And so keeping on top of all the new studies coming in is really amazing, and definitely an area that I'm very interested in. I'm wondering, I just have a question for Jenna and one for Susie. So Jenna, it seems like the NDBIs were the strongest in terms of outcomes. And I guess I wanted to ask you a question about the outcome study you did.